Andy Belcourt, who teaches in the School of Pharmacy and in the School of Community or Public and Community Health at the university. And she is also, is it like the health equity kind of coordinator
or something?
Yeah. So she's going to be either one, and so we're really lucky to have her because she's super busy with research too, and so we're glad to have you here. Welcome.
Hey, thank you. Hey.
Well, there's going to be time for questions at the end as well. Annie, do you mind if people ask you questions?
During either or at the end. I brought some resources for you for later to take a look at. Really small font, I apologize about that, but we'll circulate an electronic version that you can actually see like a normal human being. I hope I'm projecting okay. I have a little bit of a cold I'm coming off of, so let me know if you have trouble hearing me in the back. But first I'd like to just introduce myself. So Oki, I can always mess this part up. Nistu Natanako Amanisiaki, which is in Blackfeet Otter Woman, which is also Midaboge in Hidatsan. So I'm actually a multi-tribal person myself. I grew up on the Blackfeet Reservation on the northwest part of the state, and I'll talk with you about some of the things I've sort of learned recently and over the past few years. I am an alumni of the University of Montana. I'm a clinical psychologist by training, and I'm a professor, and I teach and do a lot of research actually right now, primarily public health research. Since I am trained as a psychologist, I tend to do mental health things, but also have been doing a lot within environmental health and really looking at environmental health inequalities that face tribal communities throughout the country actually. So I probably won't tell you a whole lot about the research piece, but today, just to get a sense, and I won't do introductions because I'll probably take the hour, but can you just give me a sense of what departments you all are coming from? Maybe just give me a few shouts out. I know there's some folks from environmental. Okay, any other?
Home visiting.
Home visiting, okay.
Nutrition.
WIC, nutrition, okay, great. Administration, okay. Any others missed or?
So we have health promotions, but then we also have some people here from they're recipients of the mill levy for substance abuse prevention.
Oh, okay, great.
Yeah.
Okay, great. Well, that's really helpful for me to know, just so I know, how many folks are from Montana? So, okay, great. From elsewhere in the state or in the country? Sorry. International. Oh, hey, all right. So a lot of diversity within the group. So I kind of intentionally had this be sort of an introduction. For some of you, this will be very much, this information, but for some of you, this may be new information. So please feel free to ask questions as we go, or if there's a burning question that you have towards the end, we can have some discussion as well. So we really want this to be interactive and something that is ultimately helpful in your work as you move forward. So I do teach at the university. I teach an undergraduate class in pharmacy and then a graduate level course. And we have a new PhD program in public health that's just gotten accredited. So if you know people who want to get a PhD in public health, please send them our way. But today, I want to talk more about sort of what are some of the things that you all face each day, some of the sort of underlying kind of factors that you may see when working with diverse populations. And this applies primarily focused on tribal communities, but it could apply to a number of different diverse communities. And so we'll think about how this may interact with our discussion. So this is a photo some of you may have seen before. It's a photo that represents a Blackfeet lodge. And so for our tribal ways, the area, so a teepee, if you've seen a teepee, the area of the back of the lodge is really meant to be like a place of honor. And so we have two elders, a male and a female, and at the very back is a baby, an infant. So this is sort of really my biases, I guess, but in terms of thinking about public health is really the recognition that family, community, and culture all matter, and how we interact with each other, and how we approach our daily challenges, as well as the things that keep us motivated and happy and all those different things. So in terms of thinking about prevention and health, we really, as Native people, we really want to see and share and invest in the strengths and solutions that are within our communities. So that's definitely where I'm kind of coming from. I will be talking today about some of the things that are challenges, and that are significant challenges for tribal people in our state. But I want to kind of come back to this at the end of our talk and how we can promote public health in different, more effective ways potentially. So our objectives, sorry, I teach a lot of classes, so I have to object, So what we're going to do is just have a general overview of American Indian communities within the state of Montana. Have a little information about sovereignty. What is sovereignty? What is self-governance? Why does this matter to public health? And then an overview of community health and health disparities. So part of that is going to be looking at both risk as well as protective or resiliency factors that tribal communities have. So that's the big picture. So this, in case you're wondering where you're at right now, we're in the state of Montana, and we're in Missoula. But larger than that, we're also part of what's called the Billings IHS area. And that includes both the state of Montana as well as Wyoming, which is cut off here. But in terms of tribal nations within Montana, we are the indigenous population to this country and this state and all these different things. And so when we say Native American or American Indian, we're talking about over 560 federally recognized tribal communities. So a lot of diversity within that. Another 200 are seeking federal recognition who may have state recognition. So within our state alone, we have, this is a list of the tribal names. So what you'll find is speaking with Native people is that they prefer their own tribal language. So a lot of these names are very anglicized versions. So Blackfeet, as an example, was probably given to our tribal community by other groups. And so there's different stories about how that may or may not have happened. So some tribes are beginning to rename their communities. So the Fort Belknap, you hear Ani Nakota. So you're hearing more of the native languages both being reclaimed within our state and within our communities, as well as being used. And for any of you who've driven up to Flathead, you'll see their signs are both listed in both languages. They're, I think, Salish. I don't know if they're in Kootenai or not, but you'll see some of that language immersion. So there are 7 reservations, and then there are multiple urban centers. Here in Missoula, we have the Missoula Urban Indian Health Center. So many of you may be familiar with their work. They're not an operating clinic, but what they do is they do health information and referrals. And as we'll talk about, they're also looking at providing what they call trauma-informed care. So thinking about the issue of trauma and how that impacts health. So we'll talk about that a little bit. This is just in terms of recent census data. We know that since the census changed so that you could do self-reported racial categories, that our population has increased quite significantly. There were 5.2 million people who identified as American Indian Alaska Native, 2.9 million who identified as American Indian or Alaska Native alone, and 2.3 million people who said that they were a combination of different cultural or racial groups. So, and that's reflective of some differences and changes within our population. In terms of Montana's American Indian population, we have about 66,000 Native Americans living in our state. In 2010, that increased to about 78,000. So it's a growing population. And for the state of Montana, having just cracked 1 million, we are the largest minority, if you will, group within the state of Montana. So it's important to have some working knowledge about our populations. In terms of demographics, I mentioned this already, but highly diverse tribal communities within the United States. Different languages, cultures, customs, economies, all different things. So we have over 500 tribal groups. We're a young population. 33% of our population is under the age of 18. We have significant intertribal diversity, and that has to do with our histories, our creation stories, our political structures, languages, economic lifeways. So for example, for the Blackfeet, historically relied heavily on the buffalo as a means of economics, as well as all different kinds of things ceremonially. Familial lifeways and kinship patterns differ as well by different tribes. And then a lot of people have really been thinking about this concept of historical trauma, and historical trauma being, the fact that American Indians faced a population collapse, and many would describe it as genocide for many reasons. We had a lot of disease, when about 90% of the population that passed away following contact was due to diseases and things of that nature. But there was also direct warfare and different things such as the boarding school era, where Native children were removed from homes and sent sometimes thousands of miles away from their homes forcibly, and forced to speak English, and these sorts of, and a lot of abuse history that was described as part of that process as well. But also a lot of historical resilience, a lot of people who really had to work very hard to maintain their languages and their culture. So anybody know the year that Native Americans became citizens of this country? 1924. So that's the year that we became citizens of our own land. The year that we had religious freedom. Anybody? 1978. So prior to that, it was actually illegal to participate in ceremonies and speak your native languages. So those things are within many of our lifetimes that these changes occur. So when you think about that, you think about the strength that it took to maintain our ceremonies, our ways, our belief systems, languages. It really took a lot for people to survive and to thrive in different ways. So when we talk about today, we'll talk about some of the disparities. And the disparities are really within that context. You think about that historical context and you can't really separate them out. So we do see disparities in educational outcomes, health, as we'll talk about more, socioeconomic, and these things come through in the way of poverty, housing shortages or inadequacies, and then dropout rates and disparities. So each of these points could be a lecture, right? So I'm giving you like the overview, like the snapshot view. So tribal sovereignty, for those of you who may not be so familiar with this, basically when the United States government came into contact, and other governments, with Native people, they started to develop what's called treaties, and those were legal agreements between the federal government. And what they did is they established what's called fiduciary responsibility for tribes for a couple different domains: education, healthcare, law enforcement, housing. I forget education. I may have said education already. So in terms of our region, we had the Fort Laramie Treaty of 1851, which the Blackfeet notably did not sign. The Lame Bull Treaty of 1855. So these are just some of the kind of, if you're interested in the history piece. And then what they did, sort of collectively, these treaties established what's called self-governance and sovereignty for tribes that is established by federal law. So we're kind of like dual citizens. You can be citizens of a tribal nation as well as American citizens as well. So those gave the tribes different things: a right to define tribal laws on their lands, healthcare provision, so it can be run directly by the tribe or the Indian Health Service. It gives people the rights to regulate research, as an example. So it's unique to American Indian and Alaska Native people. So these are things that other populations within our country don't necessarily have. The key is that tribes have the rights to own their own data, as an example, provide healthcare methods and define what that looks like, housing, law enforcement, and regulate research. So those are some things that make working with tribal communities different than working with another population. In terms of poverty, so I wanted to kind of walk you through some of the things that may be challenges for Native people. Montana, overall, is one of the poorer states in the Union. We have a poverty rate that's about 14% when you compare that to the national of 13%. So the 17th highest poverty rate in the country. Now, when you look at the counties that have the highest poverty rates, and the map to the left shows the reservation communities. What we see is Roosevelt Glacier and Bighorn have the highest rates of poverty. So any guesses where those are located at? Yes. So Roosevelt corresponds to Fort Peck Indian Reservation, Glacier, where I grew up on the Blackfeet Reservation, Bighorn, which is part of the Crow and Northern Cheyenne by Billings. Now, the next table will show you by reservation what do we mean by poverty. So you can break it down by a different way. You can look at the overall poverty rate, unemployment rate, and then the percentage of children who are eligible for federal programs like free and reduced lunches. So if you look at this by, so we don't have data for Little Shell, unfortunately, for everything, but the bottom row shows you the Montana rates for each of those different domains. And what is the pattern that you notice when you compare each of the reservations to the overall health of the state of Montana? Yeah, we're talking some pretty significant gaps in terms of income. So on each of the reservation, including Flathead, where there's a lot more checkerboarding, a lot of non-natives who own lands, frequently the more economically viable lands as well. Even within our reservation communities, we see inequalities and significant inequalities. When you have an unemployment rate of 68%, and 80 to 90% of your children are eligible for these different programs, you start to see the challenges that people have every day of getting their kids to school, of getting the trash taken out, of all the things that maybe you all are facing. People, in terms of the hierarchy of need, are really trying to survive, are really trying to kind of put food on the table. And this has a direct impact on nutrition and factors like that, because if you don't have enough money, are you going to go to the good food store and get fresh produce every day? Not necessarily, right? Because it's not going to necessarily last you through the month. So you're looking for things that may be less nutritionally quality, but can keep people full, so your grains, your pastas, your box meals, your canned meals. And part of that also goes back to federal programs called the commodity program. And historically, those are present on all of our reservations. But historically, their nutritional quality was really quite poor. And so you look at what we call native foods nowadays. I mean, it's changing a lot. But you think of an Indian taco, you think of fry bread, are those traditional foods? Really no. I mean, they are kind of doing the best they could with like your white flour, with your oil, your lard, your chili, your beans, or those sorts of things. So people are really trying to make the best of what they could out of times of starvation very frequently. So something to kind of help to contextualize what we're talking about. So this turns back to a classic for public health people, the social determinants of health, right? We hear this a lot. How do we address health, education, and economic disparities that require multiple domains of response? So there's not just one thing that we're going to do that's going to fix the problem of health inequalities. What we have to think about is the system that supports some of these inequalities. And since I'm a researcher, I'm all about trying to figure out what those things are and compartmentalize them and think about how these things interact. But all of us can really play a part in unpacking that box and thinking about how do we address poverty? How do we address the issue of differential treatment of members of our society, which is really what's happening. When we see maps of Missoula, there's, I think, a great map on your website, right? That's an interactive map. And it shows like walkability, it shows income, a lot of different.
Some obesity and other health, and just where parks are located.
Exactly. And when you map that on to who's living there, it's more frequently going to be native people who can afford to live there because it's less expensive. And that's true for any population. We've seen these similar maps in urban areas, people of color living closer to higher pollution, rates of pollution and things of that nature. So if you're interested in this, and I'll provide the slides, you can take a look at Professor Marmot is a European public health sort of landmark researcher who looked at health inequalities. And there's a great website that talks about social determinants of health. But it's really looking at policy, practice, science, and evaluation, and how all of these things can help inform practice to reduce some of the disparities that we'll see. And we'll talk about some of the disparities. When we talk about first health disparities, what we want to think about, well, one of the things we think about is life expectancy. So how long can you hope or expect to live is a question. So for natives who are living in Montana, the overall life expectancy is 68.9 years, which if you think about it, United States average, roughly 77 years. So a pretty big gap when we look at that. So American Indian males in Montana, it's even lower at 65.8%, years. American Indian females in Montana, 72. So you begin to see who is most at risk in many ways. So even for natives living throughout the nation, Montana is experiencing some inequalities there as well. So we have to think about the context of poverty as well as access to quality care. So people may have access to care of some kind, but it could be poor quality, or there could be cultural factors that lead people less likely to get screened or to access care. So those are some of the things that I think we could all become engaged in, is how to make things more accessible for people who are marginalized within our communities. So disparities emerge across the lifespan. So these are some of the big disparities, if you will, that face American Indian and Alaska Native communities. These are things like chronic liver disease, cirrhosis, diabetes, type 2 mellitus, unintentional injuries, assault, homicide, intentional self-harm, suicide, and chronic lower respiratory diseases. So in terms of differences, some of these face other populations as well, so it's not like it's unique to Native people completely, and we'll talk about that a little bit. But unintentional injuries is quite high, so seatbelt use, helmet use, people who are working in really difficult, like logging industries and things of that nature. Type 2 diabetes, childhood obesity, something a lot of people have been interested in looking at. Native children are twice as likely to be overweight and 3 times more likely to be obese. And dental caries is another significant factor. We see children developing dental cavities very early and having to have more serious medical intervention for those cavities. And then mental health, we'll talk more about this, but higher rates of PTSD, depression, and substance use disorders. So, and this all makes sense to a degree, not unique to Native people, but very much associated with people who are living in poverty and discrimination. So we'll talk about each of those. Mortality rates, the Billings IHS area, so Montana and Wyoming, has the highest rate of years of potential life lost in the nation. So we look at that 120 per 1,000, which is over 2.5 times the US rate. So we're seeing people losing their lives earlier and having a lot of chronic grief and loss within communities as well as families. In the Billings area, what we looked at is the percent of death. This is IHS data. Cancer being the first, so a lot of preventable things like tobacco use. People can smoke in many casinos on reservations. Unintentional injuries, heart disease, chronic liver disease, and diabetes mellitus. Sorry, I'm kind of going quickly, but I'm trying to get through the... If you need me to slow down, I can slow down. In terms of mental health, these are some of the big things that we are concerned about as a field for Native people. Suicide, and I'll talk about what that looks like in Montana. Post-traumatic stress disorder, both within our civilian and our veteran populations. So Native people tend to serve in the military at a higher rate than any other group in the country, and for many reasons. Major depressive disorder, substance abuse disorders, and then a lot of people are beginning to focus on childhood trauma exposures, so what's called the adverse childhood experiences. So we're incorporating that into a lot of our survey research and looking at differences in terms of both the accumulation of traumatic exposures and the timing of those exposures. Earlier and more trauma exposure is really been found to correspond with a lot of different health problems, both mental and physical problems. So suicide, I mentioned, unfortunately in 2015, Montana was found to have the highest suicide rate in the entire nation. Many reasons for that. Montana has been in the top 5 for nearly 40 years now. Suicide was the #2 cause of death for children ages 10 through 14 in our state, as well as youth throughout the different categories. So one of the things we think of is why. One of the things in Montana, we also have a lot of access to lethal means, to firearms. And unfortunately, every day we see that more and more is becoming a problem within our nation. Alcohol use at the time of an attempt tends to lower your tolerance for pain and for other things, and people do riskier behaviors as a result. For people too, if they feel like they're a burden, if they're a youth, if they feel like they're a burden to their family, sometimes that can be a factor. Social isolation. So some of our communities are very geographically and socially isolated communities. Some people have looked at altitude. I'm not so sure about that, but I included it because this comes from the Montana State Suicide Prevention Plan, so you probably have seen this undiagnosed and untreated mental illness. And that's very true for Native communities. I mean, we have 2 Indian Health Service hospitals in the state of Montana. One's in Browning, the other's in Crow Agency. And for both of those, they face a significant shortage in providers and therefore a significant wait to see a mental health provider. So it's very difficult to be treated for mental illnesses or mental health problems in general. For people who have attempted or completed suicide, also lack of resiliency and coping skills, and we'll talk about some of those. Societal stigma against depression. For men, this is particularly the case regardless of racial group. Just talking to somebody, there's a stigma against seeking mental health, talking about depression symptoms, even though they're very common and virtually anyone will at some point experience symptoms of depression. But these can all kind of contribute to the long-time issue of suicide within the state of Montana. These are some of the things that were reported by the Youth Risk Behavior Survey in 2015, corresponding to depression symptoms, feeling sad or hopeless, stopping doing some of their usual activities. So the highest rate of suicide is among American Indians, so it's 35.5 per 100,000. But it's also very high within our Caucasian population, 28.1. So it's a problem. It's a public health problem. It's something that needs to be talked about, and we need to find different ways to approach this complex problem. This was from a survey that was done within a tribal community and in Montana. And what they did is looked at total, what's called total adverse childhood experiences, the ACE scores, and then lifetime suicide attempts. So the good news is that most people had no lifetime suicide attempts, so that's a good thing. We want to see that. But what you saw is that for folks who had more of the adverse childhood experiences, you saw a higher likelihood of having a lifetime suicide attempt, and that's true within this particular population. So I won't spend a whole lot of time on this, but these are kind of matching up to what we're hearing from communities as well. So people who are experiencing more stress and loss and exposure to domestic violence and different things are having more significant mental health risks associated with those experiences. So this is what's called the Everyday Discrimination Score. So this is from a reservation community, so keep that in mind. But in terms of people's perceptions of feeling racially discriminated against or discriminated against in some way. So this can happen within a community, or it can happen, by outside members of that community as well. And what they found was, again, there was a significant, these are small numbers though, so keep that in mind, but there was a relationship between experiencing discrimination and having suicidal thoughts or behaviors. So something to think about as you look at the context of Montana and Missoula. Missoula, 92% Caucasian, so Native people are a minority population here. And I can tell you from being both a mom as well as being a community member that Native people experience a lot of sometimes subtle, sometimes very overt racial discrimination in Missoula. I mean, that shouldn't be a surprise, but for some people it is. Some people, there's a perception that Missoula is this wonderful, accepting, open place. And in many ways it is. But, I myself have been followed in stores. My children have been followed in stores. When I moved here from Colorado, my daughter is a very good student, and she was testing, at the 90th percentile for math, as an example. And the school that she went to, try not to name the school, but she was tracked into remedial math. And, tell me the reason why that might be. I don't know. I mean, I have to assume the best, that this was a mistake or something like that. But I think the reality is that for most of our Native students and youth and individuals and professionals, there's a perception that we're somehow less than. That could be academically or for many other things, but has an impact on our mental health. And one of the things that we know from other populations is that racial discrimination has a biological impact on how you function. It can weaken the way that your heart muscles react, and part of that is because there's that continual fight-flight response that you're experiencing, like, am I okay? Are my kids okay? Those kinds of things, that hypervigilance that comes, that's associated with discrimination. And this has been found in African American populations and other populations. And so, we tend to think about easy solutions to very complex problems. But the fact is that we all have biases, right? So we all have these things that we walk around with that are sometimes good. Like, I have a bias not to get hit by a car. And so I tend to look both ways, usually. Those are good biases, things that kind of are adaptive. But unfortunately, many people have developed, negative biases against particular groups. And within the state of Montana, that's frequently Native people. And so that corresponds to, a lot more challenging situations. And then when you think back to the previous chart, you think about like suicide risk and things like that, social isolation, all these different things. That's how it begins to kind of crystallize and make an impact on the health of a community and individuals as well. Yeah.
Thanks for the question.
Sure.
In terms of total EES score, is that strictly for racial discrimination, or does that include LGBTQ?
This is for everything. This is like everyday discrimination. So sort of like the literature on like microaggressions or those sorts of things. So those cumulative little things that wear on you throughout the day that kind of build up. So it can include that as well. And this particular study did also look at the issues associated with LGBTQ and looking at that relationship between substance use and mental health as well. So, but it's a very small N when you look at this. But it's a part of a larger study where they did with the tribal colleges throughout the country. And so there'll be some interesting things that'll come out of that for sure. But definitely that's a whole other topic, but an important topic to think about. Yeah, so we'll come back maybe to that, but great question. So in terms of risk and protective factors, we think about risk in many different ways. Of course, we've talked about some of the big picture things. We talked about, poverty and those sorts of things. But also, as I mentioned, exposure to trauma, particularly assaultive interpersonal trauma. And that could be familial trauma exposure, domestic violence, those sorts of things. Early exposure to abuse and neglect. So for any population, we're finding more and more that neglect can be just as profound in terms of its impact on your development as abuse. So we really want to think about that and how we interact with that. Substance use and abuse, we've talked a little bit about that, but clearly that's a risk factor for health in both biological and social ways. Isolation and cultural estrangement. So, when people move away from the reservation, that can be a really difficult thing. When I moved here in 1992 for college, I remember that first year was incredibly difficult because it was culture shock. I was used to living on a reservation, basically interacting with almost all Native Americans, other than maybe like a few teachers and their kids. But coming here was like the big city for me, and it was a big change. And I know others have had the similar experience. And so frequently, there's, it's hard to navigate that kind of different world. And so people, for one thing, you try to find other natives who, and that is an adaptive thing. But then also, it takes a while to learn. Like I had to learn, I can use Curry Health Center. I'm a student. I didn't automatically know that. I had never had health insurance coverage until I graduated from with my PhD, actually. So it took a long road for me to get health coverage. And I had 3 children, so when I was in graduate school, I'd have to drive to Browning to get prenatal care, and so that's a pretty long drive, 4.5 hours. So you think about that, and I use personal examples just because these are some of the stories that you may or you will have heard as people are maybe unaware, unfamiliar with how to do these things. We have a lot of instances of discrimination around renting properties. They'll see a name that's like a probable Native American name, and there's a lot of studies done nationally that have shown people are less likely to rent to people who are different than them. Jobs, same way. So some of those things are important to consider. Lack of access to healthy foods. I kind of mentioned that briefly, but for many of our Native communities, there may be one grocery store, there may be like a gas station. They're called what's called food deserts, really. So it's really difficult to find and have access to healthy foods. Safe environments as well. So in many of the communities, there may not be walkable sidewalks. They may not have them plowed. They're stray dogs, stray horses. Literally, like there's a lot of people who hit horses and cows, and that's a big public health risk on at least our reservation, but many reservations. So those sorts of things have an impact on people's behaviors, of course, right? So if it's not safe to go out, or if it's freezing cold, you're less likely to want to go take a walk. If you're worried about getting run over, or something like that. Literally there are some safety issues that are very much at play. And that pertains to Missoula too. Where a lot of Native people live are more affordable parts of town. And as we've kind of talked about, maybe less likely to have the sidewalks and access to parks and all those different things. So when I teach some of this information to students in our health professions, the one question I always get is sort of like, well, how can we get people to get compliant? Which was like, I'm like, I don't know, but when you think about, some of the things that people are facing, and then you kind of try to simplify it to take that pill at that time and da-da-da-da, it's hard. It's a challenging thing for anybody, and for anybody facing these things, regardless of your background, it would be challenging. But there's also a lot of resiliency and protective factors. I mentioned this, social support is a huge thing for Native people. Self-esteem, and that, I've done a number of different studies, and consistently self-esteem with Native people has come up as an important predictor of mental health. Communal support as well, so how you feel supported as a community member, as well as how you feel pride in who you are as a Native person, is a very important factor. Cultural factors and spiritual practices. is something important for all populations, really, to have some sort of way of making sense of our lives. And that doesn't have to be like a formal religion. It can be, just having some faith-based approach. But trauma, when we come back to trauma, we have to kind of face some of the facts of what we're experiencing within our communities. American Indians are twice as likely to become victims of violent crime in this country. We have a homicide rate that is 1 to 4 times the national average. Child maltreatment, we see American Indians with comparable outcomes to African American children in this country. So a lot of children who are in foster care, who are in challenging situations. Unfortunately, in Montana, I just pulled this off the website, but when you look at racial distribution of adult offenders in the state of Montana, 80% are Caucasian, but 17% are Native American. And remember back, we're 7 or 8% of the state of Montana. So, it's over double that we have who are incarcerated in the state. When you break it down by gender, the Montana State Prison for Women, 64% were Caucasian, 35% Native American, 77% of male inmates were Caucasian, and 20% Native. So definitely some inequalities. And those could be for many different reasons, right? I mean, this criminal justice system, believe it or not, is not colorblind. And, sentencing differentials for Native as well as African Americans tend to exist and impact how long people are sentenced for, whether they are eligible for bail, parole, those different sorts of things. So these are some of the issues that our communities are facing. And if you think about it, and then people are coming back into communities, these are small communities, so it has a big impact on these very kind of close-knit communities in terms of all these different things, in terms of exposures. Okay. So protective factors, I kind of want to make sure I kind of reiterate this, given the audience, public health, and many things you can do to make things better for everyone. But access to care, getting people on insurance, as an example, getting people to the places they may need services from. That could be WIC and all these different things that people can really help people in different ways. Helping have strong beliefs about the meaning and value of life is known to help in terms of communities that are facing suicide risk. Life skills for not just for natives, for everybody, especially younger people, but thinking about decision making, problem solving, anger management, conflict management, social skills. So a friend of mine is, a few friends of mine are psychotherapists, right? So what do we do in psychotherapy, besides charge a lot of money? Not me, but But they teach, these are the things that we help people teach. We help people think about how they're thinking, how that impacts the way that they feel, and then the decisions that they make. And so trying to help people be more aware of those things and change those things if they're harmful. So if you're prone to depression and you blame yourself for things and you socially isolate, those are probably not a good combination, right? So you want to help people unpack some of those things. Good health, access to health care. So these are some of the things like the Missoula Urban Indian Center has really been working hard on, is like they have a community garden now. They are doing some really kind of cool programming. It's called like resiliency, gosh. Yeah, somebody else will know this.
It was restoring our spirit, but things changed.
It changed recently, but it's basically about community wellness and relationships. Yeah, and relationships and helping people kind of think about that, as well as having healthcare events where people are screened for problems. And pharmacy does iPharm events with tribal communities throughout the state, as well as the Urban Indian Health Program. Helping people find ways to have close friendships and supportive significant others, helping people access religious or spiritual beliefs based on their own, this is kind of hard because sometimes people really get reactive to that, because Christianity has a history with Native people that's complex. Let me say that, and including some pretty negative parts of our history where people were forced to become Christians and punished, as I mentioned earlier. So other things, having a healthy fear of risky behaviors or pain, having hope for the future, sobriety, strong sense of self-worth, sense of personal control, and opportunities to participate and contribute to school or community projects and activities. So those are just things that we all do to try to be healthy, happy people. Sorry, I tried to put two words together there. And then, having responsibilities or duties, things like having a pet, having things to take care of. Like, it sounds so simple, but for some people, it's, for all of us. I mean, I have dogs, and they're an important part of my family, and it's not really like rocket science to a degree. It's trying to help people have access to things that maybe we take for granted because of some of the privileges that we've had within our lives. All right. This is just something I throw up because I like pictures. But it's, for most Native people I've spoken with throughout the years, and I've been doing this for like 17 years or so, doing health research and health work, but thinking about how we view health. So for Native people, and it could be the same for others as well, but we tend to think of things in a kind of a holistic way. So you'll often see like a medicine wheel image or different things of that nature, where we think about how these different domains of health are important, and when there's an imbalance in these different domains, then we start to see illness or problems emerge. So this is just sort of a conceptual model that I work from, and thinking about how physical, emotional, environmental, and relational health domains interact, and thinking about how we can improve intervention through like early screening efforts, by educating providers about cultural barriers to accessing care. And there are barriers, which we don't have a whole lot of time to talk about some of those, but I have a resource that I actually will distribute, but it's pretty helpful. It provides kind of a little bit of the Native American Studies 101, but it also provides some sort of things to think about, and I wouldn't use it as like a prescriptive, but there's some do's and don'ts, like things not to do, things to do. But take a look.
It's really hard to read.
It's
but I
really.
will share it by email with everybody.
So email is better because you can like blow it up. So yeah, it's the font is tiny. But in thinking about that is how we think about public health. Really, is we want to think about how do we support the resources that people may have, be that substance abuse treatment, helping people access traditional healers. So we did a focus group, some students did a focus group at a community college. And one of the things that came up that was significant was that, a lot of it was youth who were being interviewed, talked about having a real significant respect for Native culture, Native language, Native practices, those sorts of things, but feeling like they didn't always have an access point to those sources of knowledge and things. And so the more that we can sort of help with that, I think that is a very important thing. So we're beginning to bring back a lot of ceremonies, like naming ceremonies and different kinds of things within the culture, and the language, of course. And we're beginning to see some real changes in how that helps improve the health of our communities. Okay, any questions about that? It's kind of like a busy slide, but those things really do sort of interact, is the point. Yeah.
So have you seen some areas or places or, I'm just trying to think of, have you seen these things be really integrated well? Because I guess I think, the way that most of us experience these different pieces, they're all really separated in the culture or in our community. And have you seen places where they're kind of put together?
Yeah, that's a great question. And the reality is it's most frequently siloed like that. You know, you kind of have like, oh, you get screened for substance use, but you also have PTSD. Well, you got to go to substance use first, or you know, or vice versa, or what have you. And you know, the reality is if people worked, you know, to help kind of holistically approach a problem, a great model that I've seen in operation occurs in Alaska. And so with Alaska Native Healthcare, they have at least one of their hospitals, South Central Foundation, yes, thank you, where they actually do holistic, they get sort of triaged across the different domains. So ceremonial needs, economic, social, and physical. So all these different things you're screened for, where your needs are, and then you're matched to those services. So it's very innovative, and I think they've begun to have a lot of you know, good outcomes as a result. So, but it's not the norm. Yeah, and Indian Health Service has tried in some of their hospitals and facilities, and it's part of their mission is to incorporate the different domains of wellness, but they also operate at about half the budget that they would need to actually fulfill those missions and those sorts of things. So, and I don't want to pick on Indian Health Service or anything, but people will tell you stories of challenges that they have in receiving appropriate health care in a timely way because of those budget restrictions that Indian Health Service faces. So, but great question. Yeah, I wish we could do more to do that. So I want to leave some time for questions and things, but a couple things to kind of ponder. So I definitely come from things from a research perspective for the most part, which is, you know, different than public health practice, I know. But in terms of what we're trying to do, we're trying to think about community-centered approaches. So what the buzzword in the research world is CBPR, so community-based participatory research. They now added a plus. So the plus is like, you know, I know they have it defined and everything, but early, frequent, consistent, and accessible communication between, for instance, the researcher and the community, and maybe the public health component, the educational component. So projects that are hopefully aimed at creating equitable, respectful, and responsive relationships between, in my example, research and communities. Those are things that I think funders are beginning to look at as well in terms of being more poised for successful outcomes. So in research, there's a history, not only with Native communities, but other communities of what's called helicopter research. Have you heard that term? So it's where you come in, gather your data, sort of surgically, sometimes literally, and then you leave, and then the community never hears from you ever again, doesn't hear the results in ways that they can understand. You know, having it sort of translated to regular people, you know, language, rather than, you know, here's a chart of, you know, chi-square values, you know, figure it out. But trying to really truly have that be equitable. And that's not always the case. You know, we have these large research grants that come in, you have your IDCs set at 30% or what have you, that goes to the university, and then you budget for your project, but very frequently you don't budget for adequate respondent compensation to help offset the cost of the community partners in terms of their effort and their time. Many different examples of ways that we could all improve some of those processes and also invest in the community that probably needs it the most, right? We probably don't need another copier or what have you at the U. I mean, although I didn't say that, university. Right now we're facing a really major budget crisis. But finding, you know, meaningful ways to translate your findings. So if you're doing a study on mental health, like I showed you some things on depression, like go back to the community and present about that. Try to, you know, put that in the paper. Write it up in a way that's a community brochure that people can read. Like that's not just jargon, you know, that says here's the things that will help people do better. Those things don't always happen in research, but also in public health practice as well. Sometimes I teach on different topics, but like sexual health, as an example, not everybody knows, what are some of the major issues in sexual health? Like, what are some of the things that we should be concerned about? Who is impacted the most by some of these, like STIs, as an example? So finding ways to translate that in meaningful ways, especially if it's like a taboo topic like sexual health. People don't frequently want to talk about it, but it's an important thing. Community members are essential to both the success of these research efforts, but also public health outreach efforts. So Elma McCormick, does anybody know her? She's a Crow woman who does a program called Messengers for Health, and she has like this little army that goes out and like helps people get screening for cervical and breast cancer screenings, and just does amazing work. And it's just literally a grassroots like effort. But she has local people who can speak Crow, who go out and actually help people feel like they can get screened. And they do like what do they call it? Pink bingos and booby bingo, and they're starting to do more with men's health too. So Alma, I think, is doing some work on getting, I think it may be prostate cancer screening and helping to really get out there. But it really does require engaging, with the community members who are, the ones who are leery. For many of the reasons I talked about, in terms of trust is one of the primary barriers. People people worry. People have good reasons to worry about interacting with institutions, who, historically, my great-grandmother was in a boarding school, and if you talk to any Native person, you go back far enough, that's probably going to be the case, that and so, like with my great-grandma and my grandma, were both fluent Blackfeet speakers, but because of this indoctrination that they had experienced, they didn't want to teach us the language because they felt like it would hold us back. And that's a very common story you will hear in working with communities. But those are some of the things I think we can also undo. You can help people learn languages, culture, practice, all those different things. So that's an important thing that I think we can all remember. So historical factors, I just mentioned this, but history really does shape health in different ways, and there's a lot of, I say mutual community distrust, sorry, but but providers who see that it's a Native patient and are more likely to order a full body X-ray or something, or do a workup on child abuse or things of that nature. Other direction, Native people who maybe are distrustful of coming in for immunizations or what have you because of some of these other different factors we talked about. So how the past and some of the unethical research or health practices that occurred, those really impact the way that people view health and institutions. And so this comes back to sort of ethics, and these are things that, for researchers, we're really guided by the three fundamental ethical principles for research, and it's probably similar to other fields and things. But first is basically do no harm, respect for people, beneficence. Respect for persons. Beneficence is do no harm, and then justice, and that's having people have access to these different things. So this is some of the ways I think public health professionals should think about how do we improve our ability to have that true respect for ourselves as well as for other people. How do we ensure that we're not doing harm? Best intentions are not the best way to justify the work that you do, unfortunately. I mean, because best intentions can get us into pretty bad situations, and there's many examples of that in the past. And then justice, working to make sure that we all have a level playing field. And that could be criminal justice-wise or civil, or, the way that many things operate. So just some things to think about as you move forward. Now I come back to the issue of disparities. So when we think about disparities, right, what we're really thinking about is like, given everything else being equal, what are the differences that emerge? So these are some of the things that we see from the Indian Health Service data. Tuberculosis, Native people, 8.5 times higher likelihood of having tuberculosis diagnosis. That's pretty crazy in this day and age. I mean, we're talking probably a small n here, but still, the fact that this is still such a problem within our communities. Chronic liver disease, diabetes, unintentional injuries, homicide, suicide, pneumonia, and influenza for children. So these are some of the actionable things for public health. Tuberculosis ties directly to environmental health. I mean, that's, if you have cleaner drinking water and all these different things, access to power and food and clean clothes and things. So these are some of the things that I think we can all make a difference on. These are some examples of people. So obviously there's a lot of people who spent a lot of time trying to work on these inequalities. And it's going to take a lot more time and effort to actually truly begin to reduce this gap. But tribally driven health initiatives, I used to be more actively involved within the Montana-Wyoming Tribal Leaders Council. So it's a group of tribal leaders throughout the state who are working on health issues as well as economic issues. Federal efforts, there's a lot of what we call CBPR grants, so grants that really require the communities to be partners within the grant. Health disparities initiative, we have a grant at the university right now that's on American Indian, Alaska Native health between MSU, and places in Alaska as well. And they're specifically to reduce health disparities for Native people. So state efforts, Montana has some grant opportunities that I'm sure you're all aware of, but that are oftentimes focused on Native communities to address some of these educational, health, and economic disparities that occur within our state. So a couple other things, Native American Center of Excellence, although it was recently not funded, so that's a bummer. But we do have Indians into Psychology, so a lot of our programs where we're trying to increase the health professionals fields. And so that's an important thing. Education, the Office of Public Instruction. So part of the Constitution of the state of Montana is to teach about tribal histories. So that's been there for, I think, quite a while. But when Denise Juneau came on board, she actually put some teeth into that and had budgetary allocation. So they actually have a really good website that has a lot of information about tribal communities in the state. And then tribal colleges too. I mean, tribal colleges are a hub for communities. They're a healthy place that people can get together and do different innovative things, sometimes in science as well. And then traditional medicine. So each tribal community has its own traditional practices and healers, but beginning to bring back some of those practices that were once illegal are an important thing. Immersion schools. So we have a number of schools that are specifically trying to bring back our languages and have children learn them early on. And then advocacy. There's many different ways to have advocacy. The urban Indians have the Urban Indian Health Center, I think it is? Institute? Yeah. I can't remember. I can never remember. Anyway, but places that actually do policy advocacy and for best practices. So there's ways that people are trying to work this. So I'll try to wrap up here. But some questions to consider. I think, how can we as a community work to promote reductions in health disparities for disadvantaged groups? So that's a huge question, right? But it is a question that would require that we all help in some way. If that's becoming more informed, if that's sharing our knowledge with others, if it's challenging things that we see and know to be wrong, those are things that we can all engage in. And then how can Montana disparities be reduced using the public health resources that we have? The people that are in the communities who are doing some of this work, how can we leverage that to begin to reduce some of these inequalities, not just for Native people, but you saw before, Montana as a state really is struggling with some significant health issues. And then what are realistic ways to reduce disparities and promote equal access to health care, to economic opportunities, to educational opportunities, all of those different things that for many of us, we may have had access to those things and not known it. You know, now I think we're beginning to see some more sort of knowledge about that, but example being, when I went to high school, we had calculus, we had physics, and we were lucky. And you're seeing less of that within rural high schools, less access to like advanced sciences and things. So it's not a good thing if you're thinking about, you know, wanting to grow a healthy, you know, robust workforce, be that scientific or health or what have you. So those are some of the things that we as communities sort of need to come together and think about and talk about in different ways. Aha! Okay, so I have talked enough. So any questions, comments? This is making sense, I guess. Okay.
You know, just kind of a research comment or question. One thing that we run into when we were looking at stuff, and sometimes when we're working with people, and we're looking at stuff, is just because the populations are smaller, especially in like an urban center, it's hard to sometimes have very specific data for your spot. But do you feel like some of this bigger picture data just extrapolates pretty well from where you are?
I mean, oh, that's a great question. I think the way that I've tried to approach that question is by using multi-methods often. So not only looking at the quantitative piece where maybe you're doing surveys but yeah, maybe you have 20 people and so can you interpret that, you know? But you know, there's a lot of you know, strength within qualitative data as well. So having interviews where you're looking at themes that emerged, how does that correspond to some of these larger data sources, those sorts of things. Those can be really effective ways of looking at research and program evaluation and how people sort of, you know, are using that information in different ways and things. But it is hard. It is hard in a very small urban area. I don't know what our population is in Missoula. I always forget. 70,000, and I think for natives it's maybe 3.
Yeah, it's like 3 or 4. It's 110,000.
Oh, oh yeah, when the students are here, probably. Yeah, yeah. So 110. So that's a small population, even if you had everybody participate in a given program. But there's ways to do that. There's also, like, really being nerdy, but there's a lot of small sample size research that can be incredibly robust. Like, you know, when you have like repeated measures over time. I mean, that's what we use in like clinical settings and things of that nature that you can get some pretty good information with as well. So there's creative ways to do it. And part of it is, you know, partnering with people too who may know some of these methods. And, you know, the university has not to plug the, you know, but we have a lot of people who like have struggled with some of these questions who could probably help. You could consult with some folks there and with socials, you know, we have social work, we have all these different departments that we, you know, try to do some good work with, but it can be a challenge. And it's a challenge like with doing this kind of work too, because you have too small of a sample size. You really, you know, for ethical reasons even, you can't really report those findings, but the tension is you want to have people who need the information get the information. That's the key. Like, I think that we sort of have to try to challenge ourselves to find a way to advocate for that. Yeah. But thank you. Great question. Any other questions?
On your CBPR grants, are they addressing specific problems like diabetes, suicide, trauma?
Yeah, that's a great question. I didn't talk a whole lot about our research, like portfolios and things, but so I'll give you a couple of examples. I have, like myself personally, I have a grant where I'm developing, not isolated, but helping to adapt a therapy for PTSD. for Native people. And it's called narrative exposure therapy. So what we're doing is we're providing training and paying for clinical hours for people who are on a reservation community to implement like a small clinical trial where we're looking at mental health. So hoping to decrease, ultimately like PTSD and depression symptoms. And then we've been engaged with other researchers who are doing similar work with like a cognitive processing therapy, cognitive restructuring therapy, which is very similar for PTSD. So we have a number of things that are mental health wise. A lot of people are really looking at diabetes and health promotion. Vernon Grant has a study that he's looking at childhood obesity prevention and is doing some really innovative things. I think he's worked with the Indian Center here.
Yeah, I worked with me and my husband in the schools.
Yes.
And got us that data back for screen time, working out, sleeping.
Yeah.
Movies.
Little like wearable devices. Yeah. So there's a lot of folks who are looking at different areas. I'm trying to think of, we have 2 large studies that are looking at indoor air quality within both tribal and non-tribal homes that have wood stoves. And we have an intervention that we're looking at introducing air filtration units and comparing that to education on sort of best burn practices as an example. So the idea there is to improve air quality and reduce asthma symptoms and lower respiratory tract infections. And so, there's quite a few initiatives, and there's many ways that people could partner with people who, say, you're like, we really need something on sexual health, prevention issues. We're seeing that as a big issue. Like, you can reach out to people, such as myself, and if I can't help you, I can probably point you in the direction of somebody who could. We actually have Nikki Graham, who works in our office, who is a sexual health educator. She used to work at SKC but we kind of recruited her. But so she's done a lot in that area. You name it, there's somebody out there who's doing some work. Suicide is something I think that a lot more work needs to be done on. I don't know, for whatever reason, people don't want to talk about it and don't seem comfortable addressing some of the issues that sort of are driving some of that. So a lot more could be done on that issue, just given sort of the magnitude of the problem here in particular. So, but thank you. Yeah. Any other burning questions? So I will be back on Wednesday if you want to hear the same talk again, or if you have questions. You have my email address.
Should I share
Sure, definitely. And we'll distribute the electronic version of this puppy. And
Slides as well,
Mhm.
probably, right?
Yeah.
You can find the links on
yeah, there should be the links and things. So,
it. Awesome.
yeah, thanks everyone. I appreciate your time. And hopefully this wasn't too painful. I'm like.